We have Dr. Sujithra, Professor, Amrita Institute of Medical Sciences. She is the head of the Department of Oculoplasty and Bioethics. She will be talking about traumatic and ischemic optic neuropathy. Over to you, Dr. Sujithra.
Good afternoon. And thank Dr. Kalamedi for including me in this instructive course. I'll be presenting few cases. So first case, his 28-year-old male. He presented with loss of vision in right eye following a road traffic accident. His visual acuity in right eye was doubtful perception of light. There was proptosis, restriction of all ocular movements. Left eye was normal, and CT scan showed fracture orbital floor, medial wall, and there was hematoma in the orbit and in the sinuses. So hematoma, evacuation of the hematoma was done through lateral candolysis and anterior orbitotomy, and fracture floor was reduced. He improved, his proptosis improved, but vision did not improve. And this case is a 57-year-old male. He presented with a decrease in vision in right eye following RTA. And he reported 4 days after RTA. His visual acuity in right eye was 6/60, improving to 6/18 with pinhole. Left eye vision was normal. Right eye RIPD, color vision was defective. And fundus was normal, both eyes. And CT scan showed fracture in the sphenoid sinus on the right wing with mild indentation of the optic nerve. So IV methylprednisolone was given for 5 days, then switched to oral steroids. Vision improved, and his field of vision is also improved. And 27-year-old lady presented with loss of vision in right eye following RTA. His right eye vision was PL+, PR accurate. There was RAPD, and fundus was normal. And CT scan showed fracture orbit and hemosinus. Again, IVMP was given, and orbital decompression was done. And she showed improvement in visual acuity and visual fields. So we analyzed about 34 patients with traumatic optic neuropathy. They presented to us, and the age of presentation is about 35. Most of them are young, and males are commonly affected, and road traffic accident is the common cause, and indirect traumatic optic neuropathy is more common, and it is commonly associated with orbital wall fractures. And among the orbital wall, lateral wall fracture is commonly associated with traumatic optic neuropathy. And 5 were managed conservatively without any treatment. 24 patients received steroids, and surgical decompression was done for 5. And eyes with poor presenting visual acuity, they had poor visual improvement, poor visual outcome. And lateral wall fracture was the most common fracture associated with indirect traumatic optic neuropathy and with poor visual prognosis. Coming to traumatic optic neuropathy, the mechanism may be either direct or indirect. Indirect traumatic optic neuropathy is the most common form of traumatic optic neuropathy. Here, the trauma causes shearing on the nutrient pile vessels, causing traumatic optic neuropathy, or the force of impact on the forehead can be propagated and focused on the orbital apex and causing optic nerve injury. Direct optic neuropathy can be either due to impingement by the bony fragment or due to orbital compartment syndrome due to hemorrhage. Orbital hemorrhage is an ophthalmic emergency that is an indication of immediate surgical management. And direct optic neuropathy can be due to penetrating injury or transection of nerve fibers or compression from hemorrhage, edema, or impingement by foreign body. Optic nerve avulsion, which is rare, and it causes severe, profound visual loss, and it presents with vitreous hemorrhage. And we have to rule out skull base injury. Here, if we suspect hematoma, we have to do CT and MRI imaging so that we'll be able to pick up the optic nerve sheath hematoma. So symptoms would be visual loss. Most of the time, we won't be able to assess visual acuity since the patient would be in ICU with loss of consciousness or orientation. We may have to depend on pupillary reflex. Signs again, pupillary reflex is very important to suspect traumatic optic neuropathy. Ophthalmoscopy, most of the time it be normal. If there is optic nerve avulsion, there will be hemorrhage. For the optic atrophy to develop, it takes about 4 to 6 weeks. So again, evaluation, that is first his pupillary reflex, then imaging. CT scan is more important if we suspect bone fractures, and if there is no metallic foreign body, then we can do magnetic MRI. So there is no effective treatment for this traumatic optic neuropathy. There are many studies which support steroid, megadose steroid, and some studies says that there is no definite improvement with steroids. So still it is controversial whether to give steroids or no steroids. But one thing is very specific, that steroid is contraindicated in patients with traumatic brain injury. So in orbital hematoma, we have to intervene immediately and reduce the orbital pressure, which improves the visual recovery. Coming to ischemic optic neuropathy, it is broadly categorized into anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, and radiation-induced ischemic optic neuropathy. So here again, 52-year-old male presented with blurring of vision. He noticed that defective vision while waking up in the morning. His known case of hypertension and obstructive sleep apnea, not on regular medication. His visual acuity was 6669. Color vision was partially defective. There was RAPD, and field showed inferior altitudinal field defect. So it is a typical presentation of non-arthritic AON. Here again, management is managing the risk factors. If the patient presents before, if there is a young patient, if the patient is young, less than 50 years, we have to investigate for hyperhomocystinemia, protein CRS deficiency, or antithrombin 3 deficiency. Imaging should be done if there is any atypical features or systemic malignancy or progressive vision loss, and MRA or CTA should be done if we suspect any problem with carotid circulation. So again, there is no definite treatment for that. We have to manage the risk factors. 68-year-old male presented, they were referred from cardiology for ocular examination. He gave history of sudden onset painless loss of vision in right eye 1 month back, and he had painful loss of vision in left eye 5 days back. Visual acuity was counting finger close to face in right eye, and left eye 6/60, and right eye disc was pale, and left eye there is pallid disc edema, and ESR and CRP was raised, and imaging showed occlusion of internal carotid artery and external carotid artery. So there is combination of NAION, or in left eye there is arthritic AION. He was started on steroids and anticoagulants. So this patient is a leukemia patient undergoing chemotherapy, and he gave a history of blurring of vision for 6 months duration. And fundus examination showed pale disc, and there was altitudinal field defect, so probably posterior ischemic optic neuropathy. So it can be either arthritic, non-arthritic, or hemodynamic compromise. Severe anemia or hypovolemia can cause posterior ischemic optic neuropathy. Here in acute stage, the fundus is normal, and in chronic stage, there will be optic atrophy. And radiation-induced ischemic optic neuropathy happens in patients who undergo radiotherapy for pituitary adenoma. So it is a very slowly progressive optic nerve disorder where there is ischemic demyelination and fibrinous necrosis due to radiation injury. Here again, there is no definite treatment. Prevent the improved radiation protocol can minimize this radiation-induced optic neuropathy. Thank you.
Thank you, Dr. Sujithra. That was a wonderful talk.